Patient-Centered Care, November 12th, 2025. Jacob Stein, MD, MPH, and Jennifer Lafata, PhD. We're going to find out a little bit more about them. And this is, sorry, one of my cursors is over what I need to read there, but wayfinding, moving from risk prediction to action on acute care events in oncology. So we're going to find out all about that. There's Dr. Stein's bio information. Dr. Stein, MD, MPH, has an active role in our ABA program at UNC, serving as the oncology liaison, a role which he greatly enjoys. He advocates for the needs of ABAs across the Division of Oncology. And collaborations are one of the aspects of his career that he enjoys most. Working with Dr. Elston Lafata on this wayfinding effort with the ABA team, as above, with Dr. Lazard in the School of Journalism, and with his surgical and radiation colleagues in the sarcoma clinical space. And I'm sorry, Dr. Stein, you had just messaged something. You want to go ahead and let us know what that was?
Oh, I think there was just a typo. It's AYA, which
Okay,
maybe didn't.
I'm glad you mentioned that, because I'm sitting here going, should I know what I know what AYA is? And I was kind of scratching my head thinking AVA. So apologies for the typo.
No
And
worries.
please see that as AYA. And then he was a chief fellow at the UNC a number of years ago, and remains closely connected with the fellowship program. He loves teaching and mentoring our fellows, residents, and medical students. What's one thing we should know about you, Dr. Stein, outside of your professional activities and background?
Well, I don't know if my wall looks quite as cool as yours, Tim, but I do love to play music, and I have a growing guitar collection to my wife's chagrin, but it's a lot of fun, and I got little kids and they love when I mess around on the guitar. So that's music is a big outlet for me outside of the professional space.
Good for you. Thank you. All right. And Dr. Lapata, we have PhD, works with smart, passionate people from all kinds of disciplines, because no one solves hard problems alone. I love that. Studies patient-clinician communication in cancer care, because communicating is caring. She doesn't just study patients and clinicians, she involves them. Their voices shape the questions she asks and how she answers them. She studies how to make decisions in cancer care better, because decisions matter. And she has a sign in her house that says, "Kindness matters." It's how she listens, leads, and learns. Dr. Lafata, what's one other thing we should know about you outside of your professional, although I think we get a sense of your compassion for your field in this introduction as well.
Sure. So unlike Jake, have zero musical talents. My talents go to the garden. I like to putter in the garden, and me and the deer are having a number of conversations these days.
Yeah.
We're not communicating very
You're
well.
not communicating, not effective.
Anyway.
Maybe communicating, but not on an effective level right now. So I get it. If I look off to my right at any given moment, I'll see between about 2 and 10. So outside the gardens, totally get that. All right. Well, thank you both. Here's that poll everywhere question. The first one is always kind of a softball. In this presentation, ACE refers to an acute care event. And this is a true false. And so we'll go ahead and go to poll everywhere. And we'll give you all about 10 seconds on this one. So maybe I was thinking in the medical area, this is a kind of bandage, but I think that doesn't apply to this one. I'm guessing that's not what you're looking for, and that true is the answer. Is that right?
Yes, they got it right. You're right. There can be ACE bandages. There can be lots of things that mean ACE inhibitors, but in this case, we're talking about acute care events.
Excellent. All right. Wayfinding, moving from risk prediction to action on acute care events in oncology. I'll turn it over to the two of you. Thank you so much.
Thanks, Tim. And thanks for the kind introduction. And Jennifer, you have a better 5 items. I need to learn to write those items like you do. So this is a really cool project, and this has been a really fun project for the two of us. And I appreciate Tim, bringing this to this seminar, and hopefully it'll be of interest to those who are on the call. This is a grant and a project that we've been working together that's been supported by NC Tracks, the Translational Clinical Science Institute. So you'll see some of their imagery throughout. I'm going to get straight into it here. Um, Here's sort of an agenda that we'll go through with a little bit of background and project overview. We'll highlight some key accomplishments. I'm going to spend a little bit of time on some of our findings and insights because I think they have some really important lessons as we think about acute care prevention in the world of oncology. And then I'll talk about some of our next steps. So we've got some learning objectives here for y'all, which is to describe the burden of acute care events, how many people are experiencing these amongst individuals receiving cancer treatment. We'll talk some through the challenges in predicting and preventing acute care events amongst people with cancer, and then we'll talk through some promising strategies to proactively identify and prevent these events. Okay, so we'll start with a little primer. And I think this is an error on my end, not on y'all's. What percent of patients getting chemotherapy end up going to the ER or the hospital? So not getting admitted, but how many end up in the ER or the hospital? Is it less than 1%, 5 to 10%, or 100%, or 20 to 50? And we've probably given enough time here. And yes, I agree with the majority here. It is unfortunately not less than 1%. It fortunately is not everyone. And I know that 20 to 50% is a pretty wide range. It's actually hard to pin down and it differs from group to group, but we do think it's pretty common, more common than the sort of 5 to 10%. I wish it were down in that range. So I'm going to start with sort of basic principles here. And this is a very simple figure that I think Jennifer put together, but that sort of helps us talk through the idea that we're thinking about. So in healthcare, in medicine, obviously, there are complications that occur amongst our patient population. And those complications can happen throughout the population. They're not concentrated all in one group or another. But when we think about, in the case of acute care events, emergency visits, hospitalizations, they are going to be more concentrated under certain individuals who have some predisposing factors that might set them up to have these kinds of complications. And so when we think about risk stratified care, we want to develop systems that help us identify who are those patients amongst whom these events are concentrated. It's not realistic to think that we're going to capture all of them in a risk stratified fashion, because again, especially in the world of cancer care, highly toxic therapies, anybody can have an event that leads to an emergency room stay or a hospitalization, and we can't catch 100% of them. But if we can identify these, subsets of people who are at higher risk, then that lets us focus our efforts. And that's where we want to intervene. And it's important to say that the way that we think about intervention depends on the level of intensity or investment from our teams to provide that care. If something's incredibly simple and can be provided to everybody, then there's no harm in providing that to the whole population. But as everybody in this call knows, we're all very busy. There's a need for nurses, social workers, pharmacists, physicians, and the list is endless of the tasks that are on our plate. And so if we can really focus our efforts on the people who are most likely to develop these problems and thus most likely to benefit from the solutions, then it makes a lot of sense to deliver that type of care in risk stratified fashion. So let's talk about acute care events amongst individuals experiencing cancer. They are incredibly common. Again, up to 50% of patients with cancer. It sort of depends on the exact population and how you define it. But certainly, I think a third or more of individuals undergoing cancer treatment end up in the ER or the hospital at some point. And many of these are preventable. It turns out it's a little hard to determine how many are preventable, but there are certain things like, if somebody has nausea that leads to vomiting, that leads to dehydration, and a kidney injury, well, that end result hospitalization had to happen by that point. But you can imagine how we could have intervened at an earlier stage and prevented that. And so there are systems to classify acute care events into preventable and not. And by those estimates, again, a pretty significant proportion are preventable. This accounts for a huge chunk of cancer care spending. So in the chart on the right, you can see that almost half of oncology spending, cancer care spending, is on these acute care events. And actually, 2/3 of the spending drives the variation. And so in some places, it's a much smaller component of the spending. And in other places, it's an enormous part of the spending. You can imagine that's just another reflection that we think this is modifiable, that we think we can make a difference in some of these events. And this is a rare target in the research world because it meets everybody's goals. Patients don't want to be in the emergency department if they can help it. Their caregivers don't want their loved ones in the hospital. Their clinicians would like to keep their patients out of the hospital. But then the health system and health policymakers all want to avoid these types of events. And certainly there's a push in healthcare these days towards value-based reimbursement. So quantifying healthcare as high quality or low quality and reimbursement models that reward what we think of as good behavior or good care, and avoidance of acute care events is a big one of those metrics that people can measure and thus tie to reimbursement. There are models out there, and I'll show a paper that our group did. There are actually a lot of models out there, but the problem is that they're not used in practice, especially in oncology. Maybe people already saw this question. So I'll put it to you guys first. Why aren't these prognostic models used in practice? We'll give you guys a couple more seconds to do this. So some people said too complicated, not enough time, difficulties getting them to work within the electronic health record, the EHR, not sure what to do with the result, and then E is all of the above. And I'll go on ahead and cut it off. I think you guys are exactly right. It's some of all of these things. And so here is a paper that Jennifer and Chelsea Osterman and Hannah Sanoff and other people from our group put together. And this is really a review of existing models. And again, there's models out there and they're pretty good and they perform reasonably well, but very few of them are used in practice. And the things that we just highlighted are exactly the reasons why they're not used. So one, I would describe as practice integration. So again, the clinicians don't know what to do with the information, or it's not within Epic or whatever EHR somebody's using. You can imagine it's a lot to ask a physician, a nurse, a pharmacist to go to a different program, pull it up and punch the numbers, and then come back to their clinical workflows and do something about it. So that's what we talk about when we say practice integration. But I think the second piece that's really important is the kind of we don't know what to do with it, that intervention tailoring. If you get a number that says somebody has a 50% risk of ending up in the hospital, what are you supposed to do about that? How can you move that forward? And so these are really some critical barriers to integration of these models in practice. So we've established what we see as our translational gap, which is that these prognostic models are developed, but they're rarely integrated into routine clinical decision making. I'll talk about our wayfinding process, but first I want to highlight that the way we've painted this gap is very much not oncology specific. We're talking a lot about oncology and cancer care and acute care prevention in oncology, but the concept here goes beyond cancer care. And this notion of risk stratified care and prognostic modeling can be used in a range of disease groups or in population health management, whether we're talking about diabetes management, obesity, mental health, sort of you name it. And this approach is a problem across healthcare of how do we identify high-risk populations and then target them with appropriate supportive services. So what we proposed is a wayfinding process to bridge this gap, which is to bring that statistical work of building a model. Don't have it take place over there in a quiet room that isn't talking to any of the clinicians. Bring that together with the clinicians, the nurses, patients, so that we can form a model that makes sense clinically and statistically, that provides us with some groups of patients that have similar risks and thus lends itself to delivery of interventions. And the second piece of this wayfinding process is to do that risk stratification strategy building alongside model development. So it's not take the model and then figure out what to do with it. It's really actively think about the way that we're going to deploy the model in practice so that that influences the way that we build the model itself. So hopefully that we thought this was a cool idea, and I think hopefully that's appealing to others on the call. So again, our big goal here is helping patients with cancer avoid emergency department and inpatient care, but it's through designing this wayfinding process, again, not only for oncology, but for other areas as well. And that's a really big focus of TRACS, the North Carolina Translational Clinical Science Institute, is figuring out how to bridge these translational barriers in research and in clinical practice. So our specific aims are to develop this predictive model, to test the effectiveness of an intervention strategy that's based on the model to reduce unplanned ACEs, acute care events, and then to evaluate the acceptability and feasibility of this process, identifying strengths and challenges so that, again, we can kind of perpetuate this and make this a tool for other researchers or clinicians that are trying to conduct risk stratified care. I'm going to pause for a moment to brag on our interdisciplinary research team. So again, when we're talking about wayfinding process and bringing everybody together in one room, this is one aspect of that is our research team. So I'm lucky to have Jennifer Lafata as a mentor and a collaborator, a really experienced health services researcher who's been doing a range of really cool intervention development and practice integrated research for many years. I bring, clinical perspective as a clinical oncologist and also as a cancer care delivery researcher. Bajat is a fantastic statistician who really has familiarity with nuanced modeling approaches. So really, we're trying to bring robust statistical methods to this. Jennifer Lehman is an implementation scientist, so helping us through the process of how do we measure implementation? How do we evaluate the ability to bring a new intervention or a new strategy into practice? Yishu is one of our postdocs. She's fantastic. She's the one who's been really grinding the analyses and giving us a lot of the numbers that I'll show you today. Sarush is a pharmacist by training who's now in his PhD program as a health services researcher. So again, has some clinical insights, but also has an understanding of the statistical methods that we're talking about. And then we're very lucky to have Solomon, who's actually a physician and a master's of science, but joins our group as a project manager and really has been helping bring this along. But equally important to that research team is, as we talk about the wayfinding process, this clinician advisory or interdisciplinary advisory panel that we brought together to be part of this wayfinding process. So these are the people that we worked with as we talked about. I'll talk more about what we did, but helped us strategize, helped us think through pros and cons of different approaches, the variables that we might use, et cetera. And I'll talk through these folks just to illustrate again that interdisciplinary nature. So Bill Wood, who's fantastic here at UNC, he's a malignant hematologist and bone marrow transplanter, but also has a big interest and is very involved in our clinical navigation program and central navigation program. Emily Ray, a breast oncologist here at UNC. Gabe Brooks, who's up at Dartmouth, a GI medical oncologist who's done some of his own research in ACE prevention amongst patients receiving cancer treatment. Hannah Sanoff, a GI medical oncologist and also our vice chief of quality. So both a clinician and an operational leader. Benyam, who's a pharmacist and a health services researcher. So again, kind of benefiting from that dual perspective. Chris Fries and Gabrielle Rock are additional outside advisors. So Chris is up at Michigan and Dr. Rock is at UAB, both with their own field of study in ACE prevention and oncology. And then this was really important for us to have Patty Morfeld, who's fantastic, has been a bedside nurse, has led the infusion center, and now has a really significant role in clinical navigation. Monica Hicks and Linnea Van Pelt, nursing leaders, operational leaders, so that We have clinicians here, we have health services researchers, we have pharmacists, but we also have, some of our frontline leaders and nurses who are going to help us deploy these interventions and think through what makes sense from the patient standpoint and in the clinic. So when we met with this group and we started talking through these ideas of building a model and how to tie interventions to it, and when are we going to deploy it and for how long, the typical approach to model development is to utilize drug delivery, drug dispensing. So you come in to the infusion center, you get your chemotherapy regimen, and you then can run a model based on the drugs that were received. And of course, you can plug in their lab work on that same day, their comorbidities, and this is how most of the models that have been done, right, in our previous narrative review that I mentioned above. But when we sat down with our team and said, look, we want to start from the very beginning. What do you want out of this information? They said, if you give us the information that somebody's at high risk for ending up in the hospital as they are walking out of the infusion center, we're too late. We need that information 1 to 2 weeks beforehand so that we can plan proactively to think about how to reduce their risk in the coming month. And that makes a lot of sense intuitively. That's actually kind of a complicated problem because it's a totally different methodological approach to doing this. And so, Jennifer, you might have been the one who cracked this at a conference or something like that. You heard about treatment plans. And basically, the way that it works with oncology drugs is, for me, I ordered the oncology treatment plan a couple of weeks before it's infused. And it's for a couple of reasons. Number one, we often have to do some pre-treatment testing. They might need an echocardiogram. They might need a port placed. And then one of the other reasons is we need insurance approval. And then we have to schedule the infusion slot. Our infusion center is incredibly busy. So me and my clinical colleagues, we're placing these orders 1 to 2 weeks before people are starting. And we figured out with our partners over at the Carolina Data Warehouse that we could pull that data and actually look at what the planned treatment course was. And so this was a significant change in our strategy. Instead of relying on dispensing data, now we're pulling in advance. That means we can estimate risk sooner. That's fantastic. The challenge is that mostly limits us to infused medications. So there are all these oral medications now, whether they're hormonal agents, whether they're small molecule inhibitors, those are mostly not entered in treatment plan format. So I just want to illustrate that as an important element of this wayfinding process, working together with clinicians and statisticians and frontline clinical personnel means sometimes we have to adapt our approach. And there are trade-offs to that, right? We've in our V1, we're calling it V1. In our V1, we're not able to include oral agents in that. We will, of course, continue the work to identify and extract those patients and build them into the model. But that's important to talk about, that we have to make concessions as researchers so that we can make this as practical and usable as it can be. I don't want to go way down this rabbit hole, but I just want to mention that we initially thought of other ways that this could alter decision making. And so if some of our oncologists said, if you tell me somebody's at 100% risk of ending up in the hospital after chemotherapy, then maybe we should revisit whether or not they should get chemotherapy. But the TRACS program had this wonderful Health Equity Action Committee with really thoughtful clinicians, researchers, community members. And what they reminded us of that's really important whenever you think about prognostic models is that there is bias in the data. And that's true of everything. There's always going to be bias in the data. And so when we think particularly about underserved or marginalized populations, they might lack access to healthcare. They might have additional challenges to healthy living, and that might reflect in additional chronic diseases that are captured in the chart. And that will then be reflected in the risk model. If we're providing additional supportive care to those individuals, I don't think there's anything wrong with it. But if we talk about withholding therapies from individuals because of these historic marginalized populations, I think that gets into sort of an ethical gray zone. And so we're really grateful to those partners for helping talk these sort of sticky issues through with us so that we didn't overstep what we did with this new information and with this data, so that it only is meant to add support and not ever to take anything away from somebody. A couple of other interesting insights, and then we'll get to some data. One is that, again, the traditional way of doing these is you anticipate risk for the first 30 days. That's the highest risk for ending up in the ER or the hospital. And so you validate day 1 to day 30, what's the risk of acute care event? Well, as soon as we brought this to our EHR analysts and partners, they said, okay, well, we'll just build it and it'll run in the background. And we said, wait a second, that's not how we validated it. That's not how we designed it. And they said, well, it doesn't really make sense to build something into the EHR that's only going to work for one day or maybe a week out of a patient's whole life. We really should build it into the system. And our navigators and our clinicians said, well, I would use it if it's there. So this, again, made us go back to the drawing board from a method standpoint and develop not only that baseline model based on the anticipated treatment, but also a follow-up model that updates with all the new information that comes to pass. So if somebody ends up in the ER a week after their chemo infusion, you can imagine that alters their future risk. If somebody ends up getting a dose reduction of chemotherapy, so they were planned for X dose, but then they get half of that, well, then their risk may have reduced. And so this repeated event, this follow-up model, enables us to capture how risk is not static, but quite dynamic, and then makes this live in the EHR more effectively and with a more valid underpinning. And the last comment to make, and I alluded to this at the beginning, when we started planning out our risk interventions, we said, okay, here will be the interventions for high risk, here will be intermediate, and here will be low. And when we suggested some relatively low touch, easy interventions for our low risk population, they said, well, why don't we just do that for everyone? And we said, well, we're doing this cool risk stratified thing, so we're going to risk stratify it. And they said, no, that doesn't make any sense. If it's not going to cause any harm, then we should give it to everybody. And so I made this point at the beginning, but it's worth highlighting again. Interventions that have no downside or no effort to scale make a lot of sense to be deployed across the whole population. And interventions that are more personnel or resource intensive, then you just are necessarily limited by the number of hours that you can dedicate to them. And so those are the things that make more sense to deliver it in risk stratified fashion. So these are all really important insights that really, even though this field has been around for a decade or more, these have not been captured anywhere in the literature. All right, let's get to the model. So we pulled basically every shred of data that we could from the electronic medical record with one really important caveat. We wanted structured data. And again, it's because we want it to be available at the point of care for the clinicians and clinical teams, which means we can't have somebody going in the back end and reading the physician's notes or reading in between the lines or calculating things. We want this to be easy and automated so that number can pop up really easily to inform clinical decision making. So with that caveat, we grabbed every shred of data we could. Patient-related factors, age, gender, race, ethnicity, disease-related factors, what's their cancer type, what's their stage, treatment-related factors, what's the class of chemotherapy or immunotherapy that they're getting, how many agents are part of that regimen, and then community-level factors based on their geocoded address. And we fitted two types of models, as I've mentioned. There's a baseline model based on that predicted treatment course that gives us that information 2 weeks prior to the date that they start, and then a time varying model that updates with new information as it comes into the chart. We've alluded a little bit to this wayfinding process, but this is really where the rubber meets the road. We met with that clinical team, we discussed our plans, we took their insights. As you can hear, we evolved our approach based on what they told us. Then we went and built a model with our statistical team. And then we came back with those results to that clinical advisory board. And we said, what makes sense about this? What doesn't? And I make this sound really smooth. Of course, there were times when the clinician said, well, why don't we do this, that, and the other? And the statistical team said, you can't do that. Like that's, you're going to break the model. So it was very much an iterative process, a back and forth. Okay, if we can't do that, what can we do? And that's what ultimately led us to the models that we developed. So we ended up with this just incredible data set. So these are all patients in the year 2022 who started a new course of therapy, again, generally infused. We limited it to adults, so it was age over 21. But essentially, other than that, we included everybody. So you can see over time, a year prior to starting treatment, presumably they don't have cancer. So there's some baseline level of acute care event rate. You get in a car accident, you end up with pneumonia. And starting about 3 or 4 months prior to starting treatment, you can imagine probably the cancer is, lurking in the background, and that event rate starts to climb. And then in the month prior to starting treatment, again, you can imagine these are people with cancer that needs to be treated, but hasn't started treatment yet. So that's the highest month, about 19%. And then when you start treatment, it declines to 17%. And then declines month over month after that, but you can see it never gets all the way back to that previous baseline. So these are folks receiving, toxic cancer treatments or dealing with serious illness. And so, of course, this is a population that carries a heavier burden of acute care events. Oops. Okay, so now we're about to show some model results. So now we get to ask you guys, what do you think will be the strongest predictor of acute care events amongst patients receiving cancer treatment? Number one, recent surgery, Medicaid insurance, ACE, so prior acute care event in the past month, or a late stage disease. I'll give you guys a couple minutes to answer. And by minutes, I mean seconds. Either one person answered or you guys are brilliant. The answer is ACE in the prior month. So let me show you some results. So here is our baseline model, and I'm going to start on the right side. The 20 most important predictors, and these are organized by effect size. So the strongest predictor of an acute care event is a prior acute care event. And that makes sense. That's why you guys were right on it. And I think this is an interesting one. Jennifer and I have talked about this a lot. Some of this may be disease-related factors that people who are, unwell and get sick and have to go to the emergency department, that's going to predict that happening again. I also think there's some reflections of people's behavior and the ways that they interact with the health system. And there are some individuals who will avoid the ER at all costs and call their clinic and go to other settings or whatever. And there are other people who, when they start feeling unwell, they go to the ER. And we don't know which exactly we're measuring that, but prior ACE is this sort of composite measure that gives us a clue for how people are going to engage in these settings in the future. And so prior ACE within the past month is the strongest predictor. ACE, in the prior year is a little bit lower. Laboratory values, so abnormalities in INR or albumin, so coagulopathy, malnutrition, heart failure is a predictor, unsurprisingly. Surgery is actually protective, and the reason is we think that that's a measure of physical fitness. So if a surgeon saw you and said, yeah, you look pretty good for surgery, that's actually probably a pretty good indicator for your wellness. And so that actually is protective for acute care events. Late stage cancer, somebody said that is a predictor of acute care utilization. Liver disease, chemotherapy as compared with immunotherapy or monoclonal antibodies was more predictive. Breast cancer relative to other cancer types was lower risk, whereas thoracic or lung cancer was higher risk. And you can see the rest here. Medicaid, I think we had on the prior slide. And indeed, public insurance with Medicaid is a predictor of risk. Let's talk about the model performance for a second here. The AUC, area under the curve, or the C statistic is 0.70 or 0.71. That's pretty good in the world of of prognostic modeling, but I understand that's a number that doesn't kind of intuitively make sense. So look at the first category. If we target a sensitivity of 20%, I don't know if you guys can see my cursor. Um, look at these two numbers. So if we determine the high risk group using this set, they have an event rate of almost 50% in a 30-day span.
And Dr. Stein, just to let you know, unfortunately, we don't see the cursor.
Okay, no problem. And then the observed event rate in the low risk group, second to bottom row, is 14%. So you can see that this model effectively discriminates between these two populations, individuals at really high risk of ending up in the ER versus individuals with a lower risk. And in that orientation, the bottom left number, 7.2, that's the proportion of patients that are determined to be high risk. Now, with any of these models, you can adjust the numbers with what you need out of it. And so you can capture a few more patients, higher sensitivity in the top row, 20 to 30 to 40 to 50%. That's going to capture more patients flagged as high risk in the bottom row, 7 to 10.6 to 13.7 to 20%. But it's going to be a little bit less discriminate. It's going to put more people in that high risk category, which means their observed event rate goes down 48% to 43 to 39 to 32. So some of this is a little wonky, but just to point out the model works and it can discern high risk individuals from lower risk individuals. And then you can kind of play with the number based on what a particular health system or clinician or researcher is looking for. The follow-up model looks quite similar. We'll start with the predictors on the right. Prior ACE is the strongest predictor. 2 to 12 months is next after that. And then it's a variety of comorbidities, renal disease, Medicaid insurance, systemic chemotherapy, weight loss. There's an interesting one, right? At baseline, we've had less opportunity to see if people are losing weight, but now we're updating the model based on what happens with an individual. So you can imagine somebody who starts treatment and feels better is going to do better. Somebody who starts treatment and continues to lose weight, that now adds to the model to reflect, hey, this is somebody who's having a hard time. And so I think that's really cool and illustrative. And I won't dwell on the numbers on the left, except to say, again, we can discriminate. If you look at those bottom three rows, 27% in the high risk group, 8% in the low risk group. That's because it's a lower event rate once we get out of that first month. So unsurprising. And it's not yet published. It is under review. I submitted a version late last night. I won't tell you how late. Okay, let's get to interventions. And I'm cognizant of the time here. So we did kind of a stoplight approach, high risk, intermediate, low risk. In the high risk population, the intervention that we developed or utilized is risk stratified remote symptom monitoring, RSM, or PRO, patient reported outcome measurement. This is a proven intervention to reduce acute care events. Ethan Bash and many others have studied this and have been able to show that you can reduce the rate that people end up in the hospital. You can improve quality of life. You can actually, some analyses have suggested that you can prolong survival if you're paying attention to people's symptoms. You can also imagine that this can be intensive. So you push out these surveys to patients, and some proportion of people are going to fill them out routinely. But you can also imagine if you have a 75-year-old individual who filled out the survey last week, but not this week, your question is, are they feeling better or are they feeling so bad that they can't log on? So then the nurse calls them, has to get in touch with them. Maybe they're having trouble with the technology and they need a little assistance filling out the survey. Or maybe you have identified some symptoms and then you need to work with the patient to address those. Those are important things to discover and work through, but those are labor intensive. And of course, our personnel are very much a limited resource at our health system. So aiming for the top 10th percentile of risk, started in GI, kind of figured out the workflow, and then now in breast and GU. I'm going to show you guys a couple of quotes because I think these are really illustrative of what we're trying to do. Patients often expect to feel bad, and they just want to feel better. And we can all relate to that. The patient on the left says, I've had that small side effect the past 2 treatments, but I didn't press it. I'm like, it'll fade away. So here's an individual who knows they don't feel good, but they didn't even share it with their clinician, is my understanding, because they said, it just is what it is, and hopefully it'll get better. The one on the top right really speaks to me. It was maybe feeling nauseous, but I just figured that pain would come with it during chemo anyway, so I didn't think too much of it. I see my patients for cycle 2, and I treat a lot of young patients at the AYAs, and I say, how was cycle 1? They say, well, it was terrible. I threw up. I felt awful. And I'm like, why didn't you tell us? And they say, well, I thought that's how I'm supposed to feel. So those are really important folks who you can imagine now, if you're capturing their data longitudinally with weekly surveys, you might pick up, oh, I see. Here's somebody who's not feeling well. Even if they haven't complained of it, now you've identified the problem. And then same, and again, this speaks to my patients as well. I kept saying, this is going to pass. I'm going to get over this. I'm going to feel better. But it didn't. It began to get worse. And so I knew just to seek medical attention. That's the right thing in that moment. But you can imagine, boy, would we have liked to hear it when they were feeling bad initially so that we might have intervened. One more set of quotes. Supportive medications, and this will lead us into our second intervention, seems intuitive, but it's not. The first patient says, I weaned myself off the oxycodone. It made me feel like I was in a tunnel and it was hard for me to walk. So here's somebody with presumably cancer-related pain. They need some pain management, but the regimen they're on is making them feel miserable. And so now we're at risk for acute care event either way, if they stay on the medication and continue to have these challenges, or if they wean themselves off. So this is somebody who clearly needs some outreach and connection with the clinical team to come up with a better plan for their pain. The second person actually had the right meds at home, but they weren't working. The fatigue got worse. I was very weak, couldn't hold anything down. And the Zofran and Compazine, great medications, but it wasn't eliminating or alleviating the symptoms. And then the last one is a person who had Senna because they have issues with constipation, but they felt like it made them high. They were throwing up and they didn't want to take it. So again, lots of opportunities for intervention and communication with these patients to try to find a better symptom management strategy. So our second intervention, this is the sort of low touch intervention, is what we call our Wednesday tuck-in calls or Wednesday tuck-in texts, where we text or call, depending on the patient's preference, and remind them to take their meds. Tell them to refill their medications if they're running low. And it's a little nudge to call the care team if you're feeling unwell. And we chose Wednesdays so that they're not coming in on Friday afternoons. It gives people a little time, gives our clinical teams a little time to respond. And this is one where we said we wanted to deliver it just to the low risk patients, and our clinical team said, no, just send it to everybody. And we'll evaluate it. We'll analyze it by risk strata to see does it make a bigger difference for low, intermediate, or high risk patients. But I think this makes a lot of sense to go out to everybody. And you can see from those quotes how we think this could be really a meaningful approach. All right, I'll kind of wrap up here as we head towards the conclusion. So one of the big things for this TRACS proposal is that we don't want this model to sit on a shelf somewhere, pick up a couple of citations in a journal and never be used. We want to go from research to the bedside. And so Jennifer presents this monthly to the Medical Center of Oncology Services. We are integrating this into EHR, which means not only can it be used in Chapel Hill, but it can be used at Rex, at Nash, at Wayne, anywhere with the shared EHR, means that this will be a tool that's available for other clinical settings. And, a lot of research projects spend their money developing a cool intervention. And while the money is flowing, the intervention is doing great. And as soon as the money stops, the intervention stops and the benefit stops. We were very intentional about our approach here. We spent the money to develop the tool, but then build it into the system without research dollars so that it can live on. And that's really what's happening. Sorry, I keep trying to click and that doesn't do it. So I'm sorry for the little lags here. And then we want to think about translational science, right? Again, how are we advancing the field, getting research findings off the shelf and into practice, teaching this approach or hopefully validating this approach of wayfinding, bringing teams together so that we can plan for model development that leads to intervention. And so our wayfinding process very much influenced database development, the structure of the two models that we developed, the variables that we selected as predictors, and then thinking through the intervention planning and translation. And we are we gained some additional insights, and we're still working on algorithmic fairness of models. Do these perform equally well in different populations? And if they don't, then how do we adjust them? Again, fairness, back to fairness and equity. Value proposition interviews, talking with our patients, our navigators, our clinical advisory team about what's the value add here of these risk stratified interventions, and how do we adjust them to best meet the needs of both clinicians and patients. We are pulling our data currently to really do the structured evaluation of how effective have these interventions been, both the tuck-in text, but also the remote symptom monitoring aspect. Ongoing qualitative interviews, as I've mentioned, and you've heard some of those interviews, and I think we gain so much from that qualitative perspective of patients and caregivers about how they're navigating these challenges and what leads to those decisions for ending up in the emergency department. We have just an amazing data set as a researcher. It makes me so happy and then we can dive in a little bit more onto patterns of acute care events. So the AYA population, for me, I presented this last month at ASCO Quality. Young adults have slightly different reasons for ending up in the ER or the hospital than older adults. And that lends itself to different targeting. Pain, for example, many of our young adults end up in the ER for pain. They're not used to taking their meds. They're not used to medication side effects. They don't know what to expect with treatment. And so that often might lead them sooner to an emergency department visit than somebody that's a little bit more used to navigating these self-management strategies. Patients receiving immunotherapy, Sarush is working on this to evaluate how do those reasons for admission differ for patients on immunotherapy as opposed to chemotherapy, and which of these admissions really are preventable. Again, I kind of discussed that earlier, that some may seem preventable on paper, but it's a little bit more complicated than that. Here's categories of preventable diagnoses. Pain is far and away the top. Anemia, dehydration, nausea. You can imagine some pain is absolutely, we just need to get them on the right oxycodone regimen. But if somebody else has pain that's a new abdominal problem, that may or may not be preventable. So I think there's a lot more to dig in here to understand how we can intervene on some of these. And then the last big point I want to talk about is this notion of phenotyping. Are there groups of patients that we can identify using the data and that clinical insight so that we can target interventions more appropriately? Future goals are to socialize these risk models, again, building them into the oncology care teams and working with our clinical partners to make sure they're being used in the way that is most helpful to clinicians and patients and also makes sense from a data standpoint. We just submitted a grant to look at additional funding for this concept of phenotyping, identifying subgroups of patients that we can target intervention strategies, and then lots of opportunities to explore additional model validation with our clinician advisory panels. You've again heard that those are folks nationally that are involved in that. Can we test this in other systems? Thinking about predicting specific risks, not just ACE, but chemotherapy-induced peripheral neuropathy. If we can predict who's going to develop that, then we can be proactive about starting interventions for that. I really like this next one, thinking about individuals that might be at risk for having delays in treatment. A little bit different than acute care events, but who's going to have a hard time getting started on therapy? Who's going to have a hard time completing therapy? Those are different outcomes, but they lend themselves again to this risk stratified intervention approach. And then, of course, our patients from resource challenged areas, how do we anticipate those folks and meet their needs? And we're also working on strategies to support chronic self-management, again, borrowing from other disease groups, other fields. Listening to those quotes, you can hear there's a need for people to have these tools to manage symptoms on their own without necessarily having to call into the clinic or go to the emergency department. All right, I think that about wraps us up. So we've left a little bit of time for questions. Tim,
All
how are we
right.
doing?
We are doing well. We are going to wait a couple more minutes for questions to come in. But I will say that for our audience, please get those questions in right away. I've got about 7 that I've been jotting down. I've been really enjoying this lecture, so I don't want to monopolize, but I'll ask a couple, and then we'll see if some have come in. One of the questions that I was wondering about, let me go through. Oh, the role of caregivers. Is there an opportunity to engage caregivers? We know how important they are, and for those who are fortunate enough to have an engaged caregiver, what an important role that can be. Is there a place for the caregiver in this model?
Yes, Jennifer, you want to take this one?
So we're actually working on an application right now to do, as Jake was saying, develop some better patient-centered support. So support for self-management, and part of that will be targeting caregivers. So we'll be working with Dr. Erin Kent in the School of Public Health because we know how important that is. And we actually, from our qualitative studies, see the quotes for how patients turn to their trusted friends and family members often before they seek the medical advice from their professional care team, right? They turn to their family and friends for home remedies of things to try so that they don't, in their minds, to enable them to not have to call their care team.
Gotcha. All right. Thank you. And again, if you go to unclcn.org, or excuse me, to polev.com/UNCLCN, you can go ahead and share those questions. I've got a couple of more that I'll share while I'm waiting. Our team is fortunate enough to help out with the 23 different multidisciplinary tumor boards. And we are just in awe of the collaboration between the different caregivers that's involved in those. Do you see this model, the Wayfinder model, finding its way into the multidisciplinary tumor boards?
Oh, that's very cool. Yeah, I mean, I think there are really wide applications for this. And, I think the one underpinning theme of at least how we envision this approach being helpful across a lot of different segments would be risk stratified care. So, in our sarcoma tumor board, we have reasonably high volume, but not so many that we can't discuss them all. But I know my colleagues in breast cancer, they have so many patients often that they can't all get discussed. So yes, I could see a scenario where all of these different clinical partners, the surgeons, the radiation doctors, the medical oncologists, but also the navigators, the social workers could say, together come up with a process. We can't tell them what those criteria are, but they can inform, here are the things that we think are going to influence the highest risk patients and the ones who are going to benefit from further discussion. And then again, potentially working with a statistical team or whatnot to develop a model to identify those patients. So that's how we see this wayfinding process working together to identify those individuals at highest risk who need a little more focused care and attention. So I could see that absolutely.
Good. And we're actually working now to engage a new component of EPIC into the multidisciplinary tumor board. So maybe at some point down the road, we talk with both of you about how that may have an interaction there as well. Another question, you mentioned that this is really being targeted more broadly than just cancer. You did mention specifically breast cancer and gynecological cancers in terms of some of the differences there. Are there other unique aspects of cancer or different types of cancers that you've been aware of in the process of developing this?
So, and I apologize if I'm getting a little background noise. So what I would say is, I'll make maybe two comments. One is, we gained some really important insights into, well, I'll first say it was really important to us to include all cancer types. There have been other models that have been developed that just focus on breast cancer or just focus on GI cancer. And I understand the value of those, and perhaps they could achieve better prognostic, kind of statistical accuracy because you have the smaller, more homogeneous population. But from our view, you have hampered the ability to deliver that to a whole cancer center if you're only focused on one patient group. So for us to be able to deliver it to everybody, you got to put everybody in there.
Absolutely.
The insight that led to was that we think, and this is area of further study, but that the drivers of risk are different in different cancer types.
Gotcha.
So patients with breast cancer who might be taking hormonal therapies are at lower risk of acute care event as compared with somebody who's got lung cancer and is getting intensive cytotoxic chemotherapy. That's true. But it also means the predictors of risk may differ. So somebody who's, again, maybe an older woman with breast cancer taking hormonal therapies, her predictors of risk may actually have more to do with her age and her other comorbidities rather than necessarily the cancer treatment. Whereas a 35-year-old who's getting intensive chemotherapy for, colorectal cancer, it's really the chemo. It's the chemo. And so as that, I think, has started to inform our thinking of how these different groups are experiencing risk differently, and thus the interventions need to differ for those different groups. I don't know if that answers your question.
Yeah, no, that helps, and that kind of I'll one more question since we don't have them coming in, and you might expect this one, but given some of the complexities that you're referring to as far as the algorithms here and the calculations, are you evaluating utilization of AI as a part of generating those scores?
Yes. Jill, do you want to take that one?
Do you want me to? So
Yeah.
we are in the phenotype application that we have under review. If the federal government opens back up, I assume it'll be under review. Which I think it's gonna, which is good news for all of us. Is that we would be using some more complex approaches to developing these phenotypes, right? To put these risk factors together in different ways. And then the other component of AI could be around, like right now we're limited and we're using structured information that exists within the EHR. And so using large language models, so there are other efforts on campus here through another grant mechanism that are looking at Melissa Troster, for example, is looking at imaging and being able to look at images to predict recurrence, right? And so then those sorts of factors could go into our models, or using text-based notes to identify people with cancer earlier in their trajectory, right? And as Jake has said, we've been talking about this in the context of acute care events among patients receiving infused cancer treatment. But this idea of risk stratification can be expanded beyond that specific context, and thinking about, how AI can be used all along the way, right, with this.
Yeah. Good deal. Well, this is amazing work you both are doing, and I'm very thankful to both of you, as I know our audience is, for sharing this with us. We do have references, and folks can go back and look at the slides or watch the recording of the presentation. We want to say thank you. We want to say thank you to the state of North Carolina, the people who fund that state, and the generous support from the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center for their support of the UNC Lineberger Cancer Network, and then the team, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Kim Riddick, all of the hard work, and they each play a role in making sure these happen. Don Poe for our music at the beginning.